This is where the future begins. It's time to invest in our future. It's time to help our schools improve for the future. And it's time to give our educators what they need to innovate for the future. Because the future of Texas is in our public schools.
Public dialogue and civic engagement play an important role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is a proud supporter of free Texas Tribune events like the conversation you're about to see.
So I want to begin with what is a straw man premise for this panel, and that is that if you look back from January to the end of May of last year, everybody at the Capitol was focused on public education, primarily school finance reform, and property taxes. If those were the issues that you cared about as a legislator, or if those were the issues you cared about as a citizen or as an advocate, this was a good session for you. But if those were not your issues, there's only so much time and so much bandwidth. You jumped up and down and waved your arms and stamped your feet, and really nobody paid attention to you. If you cared about other big issues, and maybe most especially healthcare, which is such a big percentage of the budget, you basically got nothing. Now, obviously, there were some bills passed and there was some progress made, but you were told come back next session. Dr. Oliverson, is that true? Do you look at the last session from a healthcare perspective and think, yeah, not a whole lot got accomplished, we have to come back next time?
No, Evan, I don't. In fact, I appreciate the softball question because I think you had told me earlier I was going to get all the hard questions.
Well, there's still an hour left, Dr. Oliverson. Yeah.
So, no, look, I would say that, so Senator Hancock and I carried legislation, very proud of the Senate Bill 1264, which puts an end to surprise medical billing in Texas. And I would say that if you are a patient and you've ever had a surprise medical bill, you certainly know what I'm talking about when I say that of all the things that we did, including property tax, the thing that will probably save the average Texas family more money at the end of calendar year is a ban on surprise medical billing and actually holding patients harmless to their in-network deductible and copay. That
Do you
was
have a
just
sense,
an
Doctor, of
epidemic.
how many people in Texas have been affected by this previously? So how many people will this bill likely affect going forward?
Well, those are two different questions. So the first question, it seems to me like that's pretty much everyone.
Yeah.
Would be especially given some of the ways in which we deliver care in Texas. There are certain situations like emergencies you can find yourself in where you just get pounded with the surprise medical bills. The second part of your question is a little more complex because of the interplay that we have with the fully insured market and the self-funded, self-insured ERISA market. We as the state are not able to apply state law to ERISA plans, and so that becomes an ever larger segment of the insured population. Your card may say Blue Cross Blue Shield, it may say Cigna or United, but that doesn't mean it's a fully insured product. But that doesn't mean it's a
Our hands on this session would rebut the idea that nothing got done, right? That it was not much of a healthcare session.
I would say it was monumental, and I would point out that we got it done in Texas in less than 5 months, and the federal government worked on it all year long and failed to
Couldn't get it done. Representative Howard, you and I have had this conversation many times, whether the legislature is focused enough on healthcare. Like Dr. Oliverson, who's an anesthesiologist, you are a nurse by training before you got into the legislature, two medical professionals on stage. From your perspective, either as a medical professional or as a citizen, or as somebody who in the legislature has cared about these issues, did you do enough last session?
Definitely not. I agree that what happened with the surprise billing was a very monumental step forward. We accomplished some other things as well. We put more money into women's health care. I have to say, though, as a caveat to that we're still looking at seeing fewer women with the data that we have than we saw back before we did all the budget cuts in 2011 and kicked Planned Parenthood out in 2013. Be that as it may, we're spending more money there. But what the major things we were talking about, there were pretty simple fixes that were going to make a big difference, and they kind of go along with some of the things you've been hearing in the earlier panels today, in terms of trying to address the issue of maternal morbidity and mortality. One of the most significant recommendations that came out of the task force looking at that, and this is a bipartisan approach that we're taking to this. This is something we're all concerned about. We have high rates here in this state, and we can't address it. One of the significant things we could have done was to expand Medicaid coverage from 2 months postpartum to 12 months postpartum. That would have cost about $75 million out of our $250
$250 billion biennial
budget,
right, yes.
and we couldn't get that done. The other thing was to make sure that kids who currently are eligible for Medicaid can stay on the plan for a full year rather than having their eligibility have to be justified again in 6 months. That procedural way of looking at eligibility has knocked off a bunch of kids who are eligible to the tune of about 50,000 kids a year who should be getting coverage, and we're taking them off of coverage. And these are not being taken off primarily because their families are earning more money. They're being taken off because they're not meeting some kind of a procedural requirement.
So the procedural change, Representative Howard, I want to come back to the uninsured children in this state because that is a topic I want to spend some time on. But the procedural change you're talking about there, or in the case of the maternal morbidity and issue, those were in the legislature's hands. The legislature could have done that on its own.
They were in our hands. $75
Right.
million, $5 million for the kids.
Could have done it.
Could have done it.
Didn't do it.
Didn't do it.
Didn't do it. Senator Hinojosa, you are the longest serving member here on stage. You have a historical perspective on this. We've been talking about healthcare probably since long before you got into the building. But put this session in context in others that you've served in. Was it your? I want to spend some. Actually, had your.
Focus on public education.
Actually, had your.
Neglect healthcare.
There was. Actually, had your.
The budget is about $85 billion. We funded the increase in Medicaid, and we usually $85 billion.
Actually, had your.
Session that we may have to make up
This. Also, you, Senator Hinojosa.
We have a shortage of doctors. We have 2 new medical schools.
Context in others.
And Dell up in Austin. There's a third one coming in, University of Houston. So we're trying to address the doctor shortage that we have in the state of Texas. In addition to that, we increase funding for residency slots, which is very important, to make sure that we have a place when those doctors graduate from medical school so they can train here in Texas. And quite frankly, for us, we also look in terms of mental health. We appropriated over $7 billion across different state agencies dealing with mental health. Our school districts, we set up $100 million for a health moratorium, mental health consortium for our public schools to focus on kids that have issues that are suicidal, who have other issues in terms of maybe hurting someone else, to identify them early in their age and provide them with the proper care.
Right.
So look, here's one of the primary issues. We deal with healthcare all the time. And quite frankly, our challenge is that our healthcare budget is growing about 6-7% a year, completely much faster than we can collect taxes from the people that pay for it. So it is a real challenge. But to me, that's a very, what I call, piecemeal approach. We identify these problems, we try to address them, but the reality is that healthcare here in Texas, every in the Rio Grande Valley, every in the Rio Grande nation among the doctors. Those are some of the fundamental issues that we have to make at some point to really be able to improve the healthcare system here in Texas.
It must be nice, Chairman Price, to hear somebody talk about an increase in mental health funding and have that not be a big shock, right? These days, we've started to get back into business, as Senator Hinojosa said, of actually putting money toward behavioral health.
It is refreshing, and I'm glad you brought that up, Senator Hinojosa, because what our office has focused on a lot in the past 3 sessions, and every colleague up here has supported and voted for and actually helped tremendously, is passing behavioral health legislation that really advances the ball, not only by way of programmatic changes and changes in policy, but in funding. So what we have seen, as Senator Hinojosa alluded to, is in our budget, which Article 2 accounts for roughly all funds, about 37% of the state's budget, we appropriate a little over $8 billion to 23 agencies across 6 articles of the budget now for behavioral health, which includes addiction services, which includes programs, suicide prevention, mental health. We passed HB 18 and 19 this session, which actually really focuses on the nexus between students and mental health.
Right. This was part of the school safety conversation that came out of some of the mass casualty incidents in Texas over the last couple of years. Right?
Actually, it is part and parcel with that. However, it was started previously in the 85th session when we tried to pass some legislation that actually didn't cross the finish line. But mental health professionals across the state and all experts agreed that diagnosed early, and most mental illness and most students or most citizens who are suffering from mental illness actually manifest that condition by the age of 14. And so what was very clear to us was that if we could go to where that population exists and actually provide some supports, for instance, HB 19 puts a non-physician mental health professional in each ESC across the state of Texas. It is supported by our local mental health authorities, and it is supervised by them, but it is the contact, the connector, the person that any school district, some school districts don't have a lot of counselors, on every campus, for instance, but you would be able to then go to that professional in the ESC and get some assistance and help and support. So those are the kind of things that were really good. And so when it comes to your initial question on was it a good session or a bad session for healthcare, it's really not a binary yes or no answer, because I think while public education, finance, and property taxes got a lot of limelight, got a lot of stories and news headlines, there was tremendous progress made in some areas of healthcare. Now, obviously, there's work to be done when we go back, as Representative Howard alluded to, and certainly there's more funding questions when we go back into the 87th session. But when it came to telemedicine legislation, what we did for FQHCs, what we did for students, for rural hospitals, what we did for licensing of trauma centers across the state of Texas, what we did for opioids and substance abuse. I mean, these are things that really impact millions of Texans every single day, and while they may not make all the headlines, they're tremendously important to the folks who live in our communities.
Well, it's an infrastructure investment, is it not, Chairman? I mean, that's it. I mean, you made, by the way, you didn't call out specifically that you had made on the mental health funding front literal infrastructure investments,
we did.
Right? Facilities that had long been in need of rehabilitation.
When you look at our state hospitals across the state, these are aging structures, and right now we took a very positive stance for Austin, for San Antonio, for Rusk, for Kerrville. But what we are looking at are state hospitals who are literally, in disrepair across the state. And yes, we need to modernize them. We need to actually look at patient allocation. We need to actually change the way we're thinking about some of our care for these patients, because what we want to do is make sure we're not, one, putting folks in the criminal justice system that don't need to be there, that need treatment, and two, those that do need treatment, that they're in the right place and can be their competency can be restored and they can be part of the community again.
As you know, the line for a long time has been that the psych wards in Texas have been the county jails. It'd be nice if the psych wards in Texas were actual psych wards, right?
But we are making progress.
Making progress on that. Let me just quickly stay with you for a second, Chairman Price, and also bring Senator Hinojosa in this, because you mentioned rural health. I'm always amazed when I read the statistics about the degree to which Texas is a leader and in the wrong direction on rural health. More than 20 rural hospitals, according to the stats I looked up again this morning, have closed in Texas since 2010, more than in any other state over the last decade. That's 18% of the closures in America of rural providers have happened in Texas over the last decade. This is an actual problem we have to solve, right?
It is a problem. And when you look at the 254 counties across the state of Texas, 70% of those are rural counties. And so when you see rural hospitals closing and unable to sustain their existence, that not only affects patient care in those communities, it affects those communities, because you have school districts that then suffer, you have communities that suffer. So
they're often large employers, are they not? Among other,
they are. Sometimes they're the largest.
Right, yeah.
And so we had Senator Perry had SB 170 that I sponsored in the House that passed to go change the funding of rural hospitals to a cost-based methodology that I think will help them in the future. It's not a magic bullet, but it certainly will help. We had the ability to get them licensed to use telemedicine at a level 4 trauma center in our rural communities. And, we are looking at funding programs to incentivize, these medically underserved communities that also are affiliated with rural hospitals to attract professionals in those regions. So I think that we do have to provide, this support to them, because they are a safety net, so to speak, in so many areas of our state. And you can live in a urban area, but if you are traveling anywhere in the state, chances are you are going to go through a rural community. And if you have an accident or a stroke or a heart attack, you're going to need a provider. And so it is important to us.
Senator Hinojosa, many of the parts of your district would probably fall into the category that Representative Price, Chairman Price, is talking about, right? Underserved communities don't have access to providers.
Well, quite frankly, my district, part of the western part of Delaware County, here in Delaware County, will continue to increase healthcare services. We go up to Jim Wells in Brooks County. There are rural counties. They struggle to have proper healthcare providers. Corpus Christi is doing well. They got Driscoll Hospital. They have Spahn Hospital. So it is a challenge. While we try to bridge that gap by creating clinics, and it's not too far off to go from one clinic if you need to go into a hospital to drive. The real challenge is in some of the rural areas out in the west and up in the Panhandle, where the population is much more dispersed than it is here.
Yeah. And in some of those communities, unfortunately, this is something that Chairman Price and I talk about a lot, telemedicine would be an option if you had the tele part. Right, there isn't actually access to broadband in some rural communities, and so really, the concept of telemedicine is mostly science fiction, right?
So keep an eye on the Governor's Council that was just created for broadband expansion in rural Texas, and we have representatives from not only the education community, the healthcare community, the business community, but it is an important thing, because if you don't have broadband access in rural Texas, you can pass every telemedicine and telehealth bill in the world for the state of Texas, but they won't be able to take advantage of it.
Right.
And I will say that session before last, we did expand broadband connectivity with our public schools across the state. So certainly the state. So put some money where our mouths were about that session before last, and I hope that we'll be doing that in the future with health.
Right, and Representative Howard, you've talked many times to me on a stage like this one about the need to increase the number of increase access by increasing the number of providers. Right, as a nurse,
yes,
you're particularly conscious of the scope of practice conversation, yes, and whether we're allowing enough nurse practitioners and others to be in the room and to be providing that kind of health care. Any progress made on that in the last session, given the access to care crisis alongside the access to coverage crisis?
There was a little progress made, but there's still, unfortunately, resistance to full practice authority, which is, as was mentioned earlier by Senator Vanderpute, allowing practitioners to practice to the full extent of their license and training. And we know from looking at, especially in rural areas, but even medically underserved areas in urban centers, when we have nurse practitioners able to deliver care without having to have this contractual arrangement with a physician, we have quality care still being delivered, and we do expand access. And the fact is that most nurses that are nurse practitioners are actually not working in a vacuum. Healthcare is a team approach, right, doctor? It's a team approach, and we know what the limitations of our skills and expertise are. A physician knows when it's time to refer to a specialist because it's in an area that physician may not have the ability to practice in. The same is true with nurse practitioners. Right. And there have been study after study after study done to show that you have the equivalent of quality care provided with a nurse practitioner who is trained in a special, narrow focus and only practices in that area. And the problem has been, especially in the rural areas where you have nurse practitioners who are working now, delivering care with the supervision, the contractual supervision required of a physician. When that physician no longer is able to provide that, the clinics close down. because the nurse cannot continue to provide the services that she or he were providing. It's dependent upon the physician as opposed to the practitioner
And
there.
so there's an
There's
option.
a lot of
There's an
room
option
for doing
available.
more.
So that would actually be something
Absolutely.
that the legislature could.
In every
Absolutely.
session, I think we've made progress in continuing to provide more independence to nurse practitioners.
Right,
Yes.
but
Yeah, we-
you still have work. Still have work to go on there.
Right.
Dr. Oliverson, on the surprise, you mentioned the surprise medical billing legislation, which I would have called out myself because as people talk about what did get done last session, that is at or near the top of everybody's list. You actually had 3 different bits of legislation you had your hands on, all related to transparency. You had the surprise medical billing legislation you mentioned. You had a bill related to forcing freestanding emergency rooms to say what insurance they accept, right? And you also had drug price transparency legislation. The through line is giving regular folks more information so they can make better choices. You consider those things to be wins from the last session.
I think those things are the future of healthcare. I mean,
Talk about
healthcare
that.
is the only industry I'm aware of in the United States where you're unable to know in advance of getting services what the services will cost in most of the time. And I just think that's ridiculous. And, look, there's a lot of reasons for that. There's interplay between, health plans and providers, and,
Right.
there's contractual obligations that come into play. And so, everybody's sort of like, well, there's, difficulty, can't do this, can't do that. But the reality is we could all be a heck of a lot more transparent about the cost of the services that we're providing up front. And I just think it's very reasonable for a patient who's shopping around for a surgical procedure, or I think as one of your panelists said earlier, an MRI, for example, to be able to go on the web and know exactly what it would cost at hospital A, hospital B, clinic C, and have that information in hand before they make that appointment.
Yeah, the
I just think that's
communications
reasonable.
revolution gives us access to information on almost every other subject.
Correct.
But not quite so much on this.
It's fascinating, it's just, so we have not had that disruptive change in healthcare that we have needed like other industries have seen. You think about what Amazon has done for retail shopping. And, there's good parts of that and there's bad parts of that. But I think you could readily argue that from a consumer's perspective, there's tremendous cost savings when these disruptive changes come in. And we need that. And if I could just say one other thing.
Sure.
And I just want to backtrack for 1 second. So Chairman Price helped me last session. We actually passed a pretty important piece of legislation that kind of flew under the radar screen. It was the most important piece of legislation from the nurse practitioner's perspective of the entire session, and that was a bill that was authored by me that removed the face-to-face requirement for supervision. So now going forward, the problem in the past and the reason it was so difficult and expensive, one of the main reasons was because you had to meet in person.
Yeah.
Now, a nurse practitioner working in Amarillo can have a supervisory arrangement with a doctor working in Galveston, and as long as they're communicating electronically or by whatever means is convenient for both of them, as long as that relationship exists, we're not going to micromanage how that relationship occurs. And I think that is going to save folks a tremendous amount of money, a tremendous amount of effort. I think it will greatly increase the number of providers that are willing to supervise and to be available for these kinds of things. And so, I think that was a big step forward.
Yeah, Representative
I have
Howard,
to
are you
say something, yes.
Boy,
Though I
there was a
appreciate
disturbance in the force. I actually had a sense of what was going on here. So go ahead. Yeah.
Though I appreciate that, there are nurse practitioners working without medical physician supervision in multiple other states doing quite well, thank you very much, without having to even have that in the first place. And this particular business model, perhaps it is saving some dollars somewhere for someone. It's not saving dollars for the nurse practitioners who have to pay these physicians to provide the supervision, regardless of what the level of supervision is that the physician provides. So there's a lot to be looking at here, including antitrust, I would suggest.
It would not be a Texas Tribune event on healthcare if there were not a fight on stage about nurse practitioners. So I want to maybe slightly shift the conversation if I can. And Chair Price, let me ask you about this. So we heard a couple of different conversations in the previous panels about the uninsured population in Texas. This is, kind of an ever thus conversation, right? Again, an update on the numbers on this because I wanted to remind myself exactly where we are now. So the last numbers from the U.S. Census Bureau, there are now about 5 million Texans who have no health insurance. That doesn't count underinsured. That's just uninsured. That was as of the 2018 numbers, including 186,000 added to the uninsured rolls in Texas in the previous year. That's basically like adding the city of Brownsville to the uninsured rolls from a population standpoint. And that's 17.7% of our population, up from 17.3% the year before, highest number and highest percentage of any state in the country. Nationally, in the same time period, the uninsured rate went up from 7.9% to 8.5%. So we're actually more than double the national average. Does that matter? I mean, it matters in a literal sense, Chairman Price, but are we thinking about this the right way to be focused on that as a metric for our success or failure in delivering health care?
Can I go back to the nurse practitioner?
All right, sure. God, you did travel all this way. Go ahead. That's
I'm
fine.
kidding. No,
Yeah.
it's a fair question because it actually is a real problem for the state of Texas. I mean, I don't think many people would tout that statistic as something
It's
that
nothing
they
to write home about,
brag
right,
about
yeah,
for the
right.
state. But the reality is we have broad disagreement within the legislature and probably within the country when it comes to universal coverage or how you pay for that or what that looks like here within the borders of our state. And I know that, for every session that I've been a member of the legislature, so for the last 5 sessions, there have been disagreements about, what can we do? What kind of Texas solution, if you will, is out there for coverage and for health care? And so, it's not that I think there is not a recognition that that is something that, has to be, dealt with in a way that makes the uninsured population, smaller in the state of Texas. But we are growing. We got a couple of things working, against us too. We've got, a state that is the fastest growing state in the country where, demographers are saying we're growing by average about 1,000 people a day.
Right, 29 million today, and if the demographers are right, the outbound projection is 54 million by 2050, so almost double the population in the next 30 years.
So this problem could certainly get worse if we don't, certainly take steps to alleviate that. And so when it comes to an issue, and if you look outside the state of Texas, and some people will talk about on the national stage Medicaid or Medicare for all, and national coverage and that sort of thing. What usually drives the disagreement within the legislative body centers around cost, number one, and the trillions of dollars that would cost for the country, but it's still a very expensive prospect for the state of Texas. Right now is not exactly efficient and wonderful, so you've got a problematic system that needs repair before you expand it. And then 3, anytime you're going to remove the patient from bearing any sort of cost, then the overutilization aspect is something that certainly has to be considered. And so I think that there's just so much disagreement within the body about what that will look like that we have been somewhat paralyzed on the coverage front.
You acknowledge that from whatever other issues did move in the last session, that specific issue, there was pretty much no movement on dealing with that. Senator Hinojosa, let me layer another set of statistics on top of the ones I gave. Hispanic Texans have an even greater challenge on the insurance coverage front than Texans. The population group with the highest year-over-year increase in uninsured in Texas was the Hispanic community. Among the large counties along the border, said 17.7% is the state uninsured rate. Cameron, 30% uninsured. Hidalgo, 30%. Starr, 28%. Webb, 28%. 4 of the 5 most uninsured counties in America are along the Texas-Mexico border. So this is a particular problem for your district, right?
Correct.
Yeah.
Yeah, but along the Rio Grande Valley, along the border, we also have the most impoverished, the highest poverty in the nation.
Right.
And we have other challenges. Sometimes people forget that here along the Rio Grande Valley, we have a lot of nationals from Mexico that actually reside here and are part of our community and a part of our economy. And they have also challenges in trying to get insurance. But for us, we still provide the healthcare services that are available to everyone and everybody. The insurance aspect, I mean, that's a problem throughout the state of Texas. Yes, it's more pronounced here in the Rio Grande Valley, but the reality is that we as a state of Texas have passed help from the federal government on the Affordable Care Act that could have helped out a lot of those uninsured folks along the border. We walked away from $90 billion over a 10-year period, if I think my numbers are correct. I mean, for us, we try to address those issues. Just because you're uninsured doesn't mean you will not get health care. Now, you may not get the quality of health care that you really need, but I think it's a challenge that we face throughout the whole state.
Well, you're not going to be turned away if you go to an emergency room. Manny Vela from Valley Baptist was up here not long ago talking about the amount of uncompensated care that they have to cover annually. We all who pay property taxes, it ultimately falls back to us to cover those uncompensated care costs. But Representative Howard, you know that the fact that you can get health care doesn't mean that it's being delivered in a way that would be efficient, cost-effective, or ideal.
Well, absolutely.
Right.
Emergency rooms are not the place to get primary health care. They're not the place to go for your medical home, but that's essentially what's being done. I want to go back a second to talking about the lack of discussion on the Medicaid expansion. And I think the points that Chairman Price made, absolutely, those are some of the issues that come up all the time and that keep us from talking about it. But the fact is that the legislature did try to address this in 2013. Dr. Zerwas had the legislation for the Texas plan that would have allowed us to expand Medicaid, but to craft something that would have worked for Texas. I remember being on the floor when we were going to have the vote that day.
Right.
And just to the polling of the members that day, there were over 90 members in the House of 150 members, over 90 that were going to vote for it, but we were not allowed to take the vote because we hadn't reached some magic number of 100. So there was bipartisan majority support to consider this, but we were not allowed to then. And then once that happened, it was dropped. And it hasn't come up again, except when a Democrat brings it up for something here or there, like Representative Busey did this time with the budget, and we had a party line.
Senator Johnson, who was just here, right?
Right, and we have party line votes on it. What I recall specifically being said back then, and has said since then too, but is we can't do this because it would just cost so much, and we can't do this because it's so expensive for the federal government. Okay, as the senator just pointed out, we just left almost $100 billion on the table of our federal tax dollars that all but, as we've heard earlier in the panel, 14 states are doing. They're taking those dollars. The federal government is continuing to spend those dollars on state health care. We're not doing it here in Texas. We're not taking advantage of the federal dollars that we have sent in. And if the numbers are correct here, we're being told that Medicaid expansion would cost in the ballpark, we would get from the federal government in the ballpark $10 billion a year. 90% of the cost. So what does that mean for the cost of Texas? About $1 billion. Now that's a lot of money. But now when you're talking about a $250 billion budget, we could find $1 billion. It's not too expensive to do. It's too expensive to not do. It's costing us much more to deliver the care that we're delivering now without that Medicaid expansion dollar.
Dr. Oliverson, you were not, may I say it, I must quickly bring Dr. Oliverson in. Dr. Oliverson, you were not in the legislature at the time that Representative Howard is talking about. You were just a lowly doctor, right? Being paid significantly more than your service to the state of Texas, I'm sure. Do you come at this differently because you're a medical professional? Do you see the issue differently? You and Representative Howard are both from the professions.
Right.
How do you view this issue?
So look, I mean, I think the Medicaid system we have is not a very good system, quite honestly. I think we make a tremendous mistake in logic, leaping to the conclusion that just because somebody has coverage, that means they have access to care. The Texas Medical Association will tell you that less than half of physicians in Texas even accept Medicaid.
But why is that?
So, because it doesn't offer a reimbursement that
And
people
who sets
want
the
to.
reimbursement rates?
And hang on,
Okay.
my turn. And I would say that there's too many administrative hurdles and burdens to providing that care. So what happens when you dump 5 million people into a system where already people are waiting, days to see a doctor? I don't think that's a very good solution.
But you could, Doctor, you could raise the reimbursement rate. The legislature has its hands on that, right?
Right. There's a lot of things you could do, but I think you got to begin by looking at the fundamental issue of, Does the fact that you have insurance mean that you have access to health care?
It's not the same thing.
It's not the same thing. It's really not. And I would argue that there are better ways to deliver health care than to just cover people with insurance, especially if that insurance is not very well subscribed by the community that's actually providing the care.
I have Senator Hinojosa wants to get in on this.
Yeah, just a quick point on Medicaid. The cost of Medicaid has tripled during the last 10 years as cost to the state of Texas. But we are driving a lot of healthcare providers away from Medicaid because of the reimbursements are too low. Not only that, we now have managed care organizations that manage the funding from the state to the healthcare providers. And they put up all type of administrative obstacles for the healthcare provider to get the money. It is a really flawed system that we have in place. And then this is the real kicker. Every session, we add a rider, an amendment to the budget that says this is a containment rider that you have to save another $400 million, $500 million to the managed care organizations. What they do in turn, they ratchet down on the reimbursements to the healthcare providers. And on top of that, then they won't pay. And the healthcare provider has to go through loops and hoops trying to get the money back and gives up. This is why we have such a low participation of medical doctors in Medicaid.
I think you're absolutely right, Senator. Yeah. I mean, I would
but
completely agree.
But those things could be addressed. They could be addressed if we chose to.
Dr. Oliverson, again, you're a medical professional. Do you believe, from your perspective as a doc, not as a rep, that the reimbursement rate should be higher?
Yeah, I absolutely think they should be higher, but I don't think that entirely solves the problem.
Right. So if that legislation comes up next session, you'll vote for it?
That.
You'll vote for it if it comes up next session to raise the reimbursement rate?
No, I didn't say that.
Okay.
What I said was that I don't think that just raising the reimbursement rate is going to solve
because the
problem,
system has so many challenges.
The system has tremendous inefficiencies
as
well. And I would point out that when you look at states that have expanded Medicaid, one of when you talked about 5 million people uninsured, one of the disturbing statistics that I keep seeing is that in states where there's been expansion, there's this ever-rising percentage of people who have previously been covered under the expansion that are seeking not to renew their coverage. Why is that? Why are they suddenly, if they were able to buy either with a subsidy or maybe be fully covered under this program, why would they decide in the next year, I don't want this anymore?
What's your suspicion?
My suspicion is that the value isn't there.
Yeah.
They don't see the value.
They tried it and they don't want to buy it.
The other question related to that, the other statistic I would point to is that you also see over time in a lot of states where expansion has occurred, we all assumed that once people had access to Medicaid through the expansion, that everyone was going to go to the primary care doctor and they would get preventive care and health care would be cheaper and it would be better because people would stop overutilizing emergency rooms. In fact, the opposite is what you see in a lot of states. ER utilization goes up in the expansion population. So that is not a working system as far as I'm concerned.
Chairman Price, back to the larger question of cost. A couple times the $250 billion budget that you all passed and implemented in the last legislature for this biennium has been called out. A couple times that's been called out. Largest budget ever passed by this legislature, or by a legislature. A 16% increase year over year, I'll note, or biennium over biennium in the budget, although the HHS spending only increased by 1%, biennium over biennium, despite the fact the costs go up. Healthcare costs are an increasingly large share of the budget. It is the case that every dollar you spend on healthcare is a dollar you're not spending on something else. It's crowding out other spending. And at the end of the day, if you all don't get a handle on this, it's going to be impossible to run a state as big and complex as Texas, right?
That's correct. When you look, you have to consider trade-offs. When you look at Article 2, which was referenced earlier, the portion of our state's budget that accounts for all the health and human services spending, when you look at all funds, what the federal government pours in and what we generate in general revenue and appropriate to Article 2, it is right neck and neck, just a little bit behind our spending on education.
Butting up to education, which would really make it, that's the first time in history that's happened, right?
And if you take out and just look at what general revenue is going into it, what state taxes are being appropriated to Article 2, it is the fastest growing area of our state budget. And so it is critical to get a handle on it, because when you look at what you are going to have to spend in the future, that takes away from what you can appropriate to transportation or criminal justice or economic development or natural resources and all the other areas of state agency service spending, et cetera. So that dovetails with what we talked about earlier. That does cause a lot of concern, or at least questions, and it shouldn't be disregarded with regard to the future cost of expansion. Because while there is money left on the table, so to speak, right now, when the federal government quits matching 90-10, which it will, how is the state of Texas actually going to pay for that? And is it going to be willing to take that money away from other articles and other areas of state spending? It's a question a lot of folks are very uncomfortable answering because it is so uncertain as to what that may look like in the future. So it causes a lot of consternation.
Right. You mentioned the Texas way, and I think Representative Howard also alluded to when Dr. Zerwas had his hands on this, the Texas way. What is stopping us from coming up with our alternative? I hear for years now what we're opposed to. Tell me what we're for. So what's the alternative? If we don't like Medicaid expansion piece, we think the system is broken. Conservative government produces conservative solutions. Also, elections have consequences, right? So then what are we for? Where's the Texas solution? When's that going to be shown to us?
I don't know that there's a real simple answer to that question. In fact, I'm pretty certain that there's not a simple answer to that question. I think that with respect to what's happening now with whether you want to call it block grants coming our way,
In fact, there's an announcement tomorrow from the federal government that they're going to begin to do block grants of Medicaid funding, much more so, stuff that Congress could not approve, but the federal government is just mandating that they're going to do that. I think that announcement's coming tomorrow.
I think that's something that as we've discussed amongst ourselves, at least many members of the legislature, I think flexibility without so many strings attached is something that the legislature would like to work with, a framework that would make them more comfortable, so that you can tailor better some services and find some cost efficiencies in areas where it has been historically inefficient.
This is where you get out from under the thumb of big government and mandates and regulation, in your mind, to allow you to do your job. Representative Howard, I promised you I'd come back to children because I do want to come back to children as a component of this conversation. Whatever else we disagree about, we probably all are pro-child, right?
I hope so.
I don't know that we could program an event with somebody on stage who is anti-child, so I'm going to make an assumption that we have a unanimity here on this, if nothing else. Right now, more than 11% of the children in the state of Texas do not have access to insurance. We are the only state in the country that has a double-digit percentage of its children without insurance. We have 21% of the nation's uninsured children in Texas, which makes us not only first, but first by a mile. And I think when you talked about the 50,000 we were losing per year, the statistic that I saw was that enrollment in children's Medicaid was down by about 150,000 in the last 3 years. That can't be a coincidence. That's got to be the data. So what do we do about that? Can we at least focus on that part, or can you not disengage the uninsured children piece from the rest?
Absolutely. And I think one of the things that some of us have been talking about is if we can't get off the dime in terms of Medicaid expansion or whatever we want to call it, can we at least look at certain limited populations that we could invest in, such as what you just mentioned, looking at children and making sure that we're putting in place the policies that will allow more children to be covered on a continuous basis. Could we look at the expansion of coverage postpartum from 2 months to 12 months to make sure that that population has the coverage that they need? And we all understand that coverage doesn't mean access. So let's just get that off the table here. We all understand that this is a multifaceted issue that requires access to providers, that requires adequate reimbursement rates. And we understand that. But the fact is you still have to be able to have some kind of coverage to get something right now. So if we had women being covered, girls who are having babies being covered for that additional 10 months, we know that in that window of time, we could have a huge impact on addressing the maternal morbidity and mortality issues that are impacting Texas women. Those are very limited populations. It could give us a chance to just incrementally do some things and make a difference in these narrow populations.
Yep.
And I think would move us further down the road toward figuring out what is going to work here so we can get more Texans the kind of health care that they need.
So rather than broad-based agreement, you would be looking for something more narrow and vertical.
If that would get us to move.
If that would work. All right. So we're going to go to questions in the audience here in about 2 or 3 minutes. But before we do that, we're in the interim. We're living in the world of interim charges. You may think that the legislature is only in for 5 months every 2 years. Joke's on you. They never go away. They never stop working. Here they are, for instance. And so they're continuing to work in preparation for, in some ways, this is really where the hard work is done in advance of the January 2021 session, which is, after all, just around the corner. So let me ask each person on stage, Senator Hinojosa first, Rep. Howard, Rep. Oliverson, Chairman Price. What is the big issue on the horizon in the interim that you're working on or that heading into the session you expect to be near or at the top of the agenda?
Redistricting.
Well, yes, but that doesn't. Yes, that doesn't relate to health care. Nice try. Give me something that has a flavor of health care coursing through it. Something. Or does redistricting actually affect health care? Because if you redraw the maps, Right.
Quite frankly, next session I see in reference to healthcare, focus on primary healthcare doctors. There's such a shortage, and they're really key to part of the team to be able to manage and oversee the healthcare of a patient. And we don't have that yet. There's a lack of coordination among the specialists and the primary care doctors. So we're going to try to focus on that.
What's your legislation, if you could wave your wand, that solves that problem?
Well, I think, quite frankly, we need more incentives so people go into primary health care.
Yep.
Doctors are now going to different specialties because they pay a lot more money than we pay our primary care doctors.
Yeah. Okay, well, that's a good answer. Representative Howard, what is the priority that you're working on in the interim or that you expect heading into the session will be at the agenda's top?
As always, the budget.
Yep.
And because of what we passed this last time with the school finance and property tax reduction to the tune of $11-something billion, we don't have necessarily sustainable revenue going forward to cover what we've done, including the anticipated compression of tax rates that's going to be moving forward with what we passed.
Yeah.
So we're going to have real challenges with how do we find the revenue. And those of us who have talked about the possibility of Democrats perhaps taking over the House would inherit this big challenge of where are you going to find the money? Whoever's there, we're all going to have the challenge.
Oh,
of where
you'd like to have that problem and be back in the majority if you could. We know where that's
$9
going.
billion.
Yeah.
Right.
But
let me just say about healthcare. The fact is that we get a federal matching amount of money that we get. We had a more favorable rating this time, so we were able to count on $2 billion more coming from the federal government this time. And rather than supplement what we were doing, we used that to supplant our GR dollars, our state dollars. So we know that next time we come around, we're not going to have that same favorable rating. So we're going to have more there.
Yep.
The House put in money to cover cost growths that the Senate and the conference committee went away. That's going to be another $2 billion perhaps there. We have all of these things adding up that we have to cover somehow at the same time that we have an oil and gas industry that is not doing as well as it was. We are still doing well with our sales tax, which is our primary source of revenue, but still, there's a lot of numbers we could talk about here. The fact is, we know when we come back next session, the budget is going to be a huge challenge to pay for what we currently have, much less look at doing anything to expand in any area.
So the budget is, in fact, the answer, it turns out. So, Representative Oliverson, what's on your mind for the interim or for next session on healthcare?
Lots of things. So I'm on an interim committee that will be looking at healthcare costs.
Right. This is
specifically.
the other Bonin is chairing that.
Yes,
Right.
So
yes.
the Doctors Club will be working on that, right? And so, no, I'm actually very excited about that. And I think we'll build on some of the transparency work that we did in the last session. Again, getting back to what I said earlier, when we think about the uninsured population in Texas, and even those who are insured but maybe underinsured, the question is, are they getting value for the cost that they're having to pay? And I would just say, as a physician, my guess is they're not. And I think we can do better, and I think we must do better. And, I think we're going to take a hard look at that. I would expect that we'll come back next year with some good ideas of legislation of how to actually bend that cost curve down. It's ridiculous to me that all the things that we've done in the last 30 years, including the ACA, not a single one of them has actually bent the cost curve down. Healthcare continues to rise. Chairman Price was talking about, how much bigger part of our budget year over year. We're not really doing anything to address that fundamental
And that's what
problem.
this interim committee is going to be
We're going to be
address.
looking at that. I'm going to be looking at things like a quarter of the prescriptions that get filled every year in Texas, in America, really. It would have been cheaper to pay cash than pay your copay. And yet people continue to pay their copays. I read a study the other day that said that a third of healthcare costs are tied up in administrative things. They actually don't go to the providers, and they're not involved in the actual provision of care. So I think there's tremendous opportunities for savings there. We just have to get smart about delivery.
All right, Chairman Price, finally, and then we're going to, if you have time for a couple questions, please line up at the mics if you want to ask questions of our legislators. Chairman Price, what's on your mind in the interim heading into next session?
I don't disagree with anything my colleagues said up here with regard to what needs to be focused on and what will take a lot of attention over the course of the next 11 months. Even though I am on redistricting, the House Committee on Redistricting, and we've had about a dozen hearings already across the state and have over a dozen left, that has taken quite a bit of time. However, with regard to health care, I'm excited about the opportunity to, one, follow up on what we've discussed today with some pretty exciting legislation from last session to make sure it's being implemented correctly, to make sure that things like, getting rid of the DRP, the Driver Responsibility Program, and trauma care funding. I mean, Representative Howard talked about how much we have committed now to funding streams that need to be sustained going forward. That's an area that we need to make sure that adequate trauma funding and that those systems are working the way they're intended to work, and that's critical for the state of Texas. And then we also need to look at the use of technology. I think it's been pretty fascinating to see how we have helped, and Representative Oliverson has done a tremendous amount of work in telepharmacy and using some of the technological advances across state to make the delivery process more efficient. We need to make sure that our prescription drug monitoring program, our Pdmp, is working the way it should be working, so that we are stemming the tide of abuse, doctor shopping, and things like that. So I'm really very encouraged with some of the legislation that has passed, not just this session, but the last couple of sessions. I think now we're at a point where, yes, we need to go forward with everything we've discussed on the stage, and the budget's going to be a huge part of that. But we need to follow up and make sure that we're always looking forward to the future, being proactive, not just reactive.
Good. Great answer. We'll go back and forth. Ma'am.
Evelia Castillo, Texas A&M Healthy South Texas. Healthy South Texas is really focused on preventive and public health education, and we are seeing some impact. Here in the Rio Grande Valley, our medication assistance has led to $6.6 million in savings in prescription cost medications. Our diabetes program, 62% of our participants are seeing an improvement in their A1C, so we are seeing some health outcomes. So my question is, what can the legislature do to continue encouraging more of a focus and investment on preventive health and public health education?
Senator Hinojosa, this has been a topic that we've discussed in every panel today, the opportunity to get out in front of these problems so that we ultimately don't need to put somebody in the healthcare system, right? This is a good issue.
Well, for us, we have set up a Healthy South Texas program where we reach out to communities to try to educate families how to eat healthier, how to focus on the most prevalent diseases here in the Rio Grande Valley in South Texas: diabetes, infectious diseases, obesity, and trying to prevent from this problem becoming a lot more serious. So we try to focus on that. And we have, quite frankly, put in about $30 million over the last two sessions on the outreach networks that we have with A&M, cooperating and coordinating with the different healthcare facilities that they have, from dental school, the medical school, the nursing school. So we're trying to focus on prevention.
And I think the regional approach is actually, something to be considered for future expansion. The Healthy South Texas program is very successful. And, I've used that as an example to push for a Healthy Texas Panhandle program using the same infrastructure with Texas A&M's AgriLife and Extension agents.
Not assuming that what works in the Valley necessarily would have to work in the Panhandle.
There is some overlap on some of the conditions of concern, but also, for instance, something very different up in the Panhandle is we have the highest incidence of skin cancer of any region in the entire country. And that could be from a lack of education. It could be, a combination of, we have a lot of folks that work outdoors.
It's hot as blazes up there.
It does
too,
get
right?
very hot and high elevation. But, the reality is something as simple as educating school children about the use of sunscreen, or just a program that could be implemented and taught would have long-term results. So I think taking a regional approach and being proactive, again, is very important.
Question.
Yeah, good afternoon. My name is Columba Wilson. I live in San Antonio. I just want to talk about the mental health. My child lost the insurance, Medicaid, when he turned 19 years old. So he ended up in jail. So for 2 years, he spent the whole time in jail. And they don't have services. They didn't send him to a treatment center because he didn't have insurance. So he went from hell to hell. He ended up in... He went in with learning disability, trauma, depression, and when he got out after 2 years, he got out with paranoia, schizophrenic.
Because let's move to a question. So
I'm
please.
sorry, that's what I'm saying.
Yeah.
That's a question that that's a question. Something needs to be done about this mental illness.
Right, and
no
Price,
medication.
We talked about this, in fact, earlier, right? This is a big topic.
It is a huge topic, and Ms. Wilson, good to see you. She's very commonly in our committee hearings and does a great job advocating for some issues where there's a nexus between criminal justice and behavioral health. And there were some steps last session. Senator Zaffarini and I worked on a bill to House Bill 601, which is actually trying to facilitate a better mechanism so that there is a better evaluation of those who are being arrested, for instance, so that competency restoration can be done both inpatient and outpatient. And with Senate Bill 292, the session before, which was a grant program that the state established for jail diversion programs across Texas, and we actually funded that. Thank you to the Appropriations and Senate Finance Committees for actually seeing the value in that and putting more money into it this time. What the goal is to make sure that we are actually treating people instead of just jailing them, because they are not going to get treatment in our criminal justice system. That's not what it's designed to do. But we need to keep folks out of it because it's better for the taxpayer, but it's better for the patient care. It's better for the person affected. So we are making some headway. We are starting to see the fruits of that labor, but there's still a long way to go.
Great. Thank you.